frequently asked questions about microcytic anemia. What is microcytic anemia? Microcytosis is usually encountered incidentally when a complete blood count is performed for various reasons. The condition is defined as a mean corpuscular volume of less than 80 micrometer cube in adults and is often associated with anemia. What are the causes of microcytic anemia? The most common cause of microcytosis by far is iron deficiency anemia. Therefore, the clinical and laboratory evaluation should first actively rule out iron deficiency anemia. Other causes include anemia of chronic disease, lead toxicity, sideroblastic anemia, and thalassemia trait. The diagnosis of iron deficiency anemia warrants additional evaluation for an underlying cause. How reliable is the history and physical examination in ascertaining the cause of microcytic anemia? Once microcytosis is diagnosed, the history can sometimes provide clues to the underlying etiology. Important history information includes nutritional intake, occupational or residential exposure to toxins, such as lead, family history of anemia or ethnicity suggestive of anemia due to an underlying hemoglobinopathy, and systemic symptoms of an underlying chronic infectious or inflammatory process. Review of gastrointestinal symptoms is warranted in adults, and a menstrual history should be obtained in menstruating women. Most patients with microcytosis are asymptomatic, and physical examination findings are often limited. Are laboratory tests alone sufficient to ascertain the causes of microcytic anemia? Laboratory investigation is the mainstay in evaluation of microcytic anemia. Laboratory tests that may help in differentiating the cause of microcytosis include red blood cell distribution width using the FBC, serum iron levels, serum ferritin levels, total iron binding capacity or TIBC, transferrin saturation, hemoglobin electrophoresis, and occasionally reticulocyte blood count and peripheral blood smears. Data do not support the routine use of other FBC parameters in the evaluation of microcytosis. To what extent does RBC distribution width differentiate the causes of microcytic anemia? Red blood cell distribution width measures the variation in red blood cell size and is often increased in persons with iron deficiency, but normal in those with anemia of chronic disease. However, this measurement is not sensitive or specific enough to differentiate iron deficiency and beta thalassemia trait. The red blood cell count can help differentiate the two causes because it is often in the high to normal range with beta thalassemia trait. What are the components of serum iron? Serum iron is a medical laboratory test that measures the amount of circulating iron. 90% of serum iron is bound to transferrin, and 10% is in the form of serum ferritin. Serum iron levels are decreased in iron deficiency anemia and, to a lesser extent, in anemia of chronic disease. What other tests can help to detect iron deficiency anemia? Ferritin and transferrin saturation levels and TIBC are useful in picking up iron deficiency anemia. They are also useful in differentiating iron deficiency anemia and anemia of chronic disease when the serum iron level is decreased. TIBC refers to the ability of unsaturated transferrin, the transport protein for iron, to bind to iron. TIBC is usually synonymous with total transferrin level. This measure is usually increased in iron deficiency, decreased in anemia of chronic disease, and normal in the less severe thalassemias. Transferrin saturation is the value of serum iron divided by the total iron binding capacity. Of the available transferrin, the main protein that binds iron in the blood, this value tells a clinician how much serum iron is bound. A value less than 16% is often indicative of iron deficiency anemia. Ferritin is a complex of iron and the binding protein apoferritin. Ferritin reflects through iron stores and is not susceptible to the short-term variations that occur with serum iron levels and TIBC. However, ferritin is also an acute phase reactant and can be elevated with liver disease, malignancy, and chronic renal disease. Iron deficiency anemia is likely if the ferritin level is less than 15 micrograms per liter in an otherwise healthy person. What is the diagnostic strategy in evaluation of microcytic anemia? After confirmation of microcytosis on FBC, physicians should first order a serum ferritin level. If the ferritin level is consistent with iron deficiency anemia, identifying the underlying cause of the anemia is the priority. If the serum ferritin level is not consistent with iron deficiency anemia, the next stage of the evaluation should include measurement of serum iron level, TIBC, and transferrin saturation. Iron deficiency anemia is still probable if the serum iron level and transferrin saturation are decreased and TIBC is increased. On the other hand, if the serum iron level is decreased and the TIBC and transferrin saturation are decreased or normal, anemia of chronic disease is most likely. If the diagnosis remains unclear, hemoglobin electrophoresis can identify beta-thalassemia trait and less common inherited causes of microcytosis. A bone marrow biopsy can help identify sideroblastic anemia. A serum lead test can detect lead toxicity.
Audio Jungle. Audio Jungle.